Ladies and gentlemen, dear friends, welcome again at the webinar organized by the International Society of Gynecological Endocrinology. This afternoon here, I don't know if you have morning or evening time, today we will have a very attractive topic, which is sexuality and gynecological endocrinology, tips and tricks. And we have invited two very experienced persons to discuss the topic. We have with us Professor Rossella Nappi. Rossella, she's an MD, PhD, gynecologist and endocrinologist and sexologist. And she is a full professor in obstetrics and gynecology, chief of the Research Center for Reproductive Medicine and director of Gynecological Endocrinology and Menopause unit at the San Matteo Foundation, University of Pavia. She is permanent member of the advisory board of the International Society of Gynecological Endocrinology, and also she is the general secretary of the International Menopause Society. The second speaker this afternoon will be Professor Peter Chedraui. He is a gynecologist and obstetrician, director of the Instituto de Investigación en Salud Integral de la Universidad Católica de Guayaquil in Ecuador. Is board member of the International Society of Gynecological Endocrinology. We have a fantastic duo this afternoon, and editor-in-chief of Gynecological Endocrinology, the official journal of the SGE. And then we will have first presentation, Professor Rossella Nappi, then Professor Peter Chedraui. Then we will have a general discussion. You can write your question in question and answer, and I will see them, and I will introduce the question to the speaker, to both speakers, but each one of them is allowed also to make if have any important reply, to reply also to the question of the other one. Then please enjoy and stay with us. Now is Rossella, please go on.
Hello to everybody. It's a pleasure to be here in our society, and it's always wonderful to be with Peter Chedraui, that is a very, very good friend. So the topic that Professor Genazzani gave it to me, you will see it's quite interesting, because I believe there is still a lot of work to do together as clinician and researcher in gynecological endocrinology. You all know this is a cartoon I produced so many years ago, that premenstrual disorders are quite common in women. And according to the methodology you use to diagnose the symptoms, they can be very highly represented. Up to 75% of women may have some kind of discomfort before the menstrual cycle. But the real premenstrual syndrome, meaning that we have a moderate to severe symptoms, is still common, but is less. It's around 20–40% of women. These numbers are influenced by many factors, most importantly, the methodology we use to diagnose, but also the social-cultural environment where we work. And I will show you some of this. Then, as you know, there is another condition that is less common, that we name a premenstrual dysphoric disorder, that it's a real psychiatric condition that affects less women, around 5% of them. And we can see as OBGYN in our office, but for sure, this condition is much more common in a psychiatric environment. What is very important as a first point, as a tip, in clinical practice is that all the time we deal with these symptoms, we have really to use a menstrual cycle calendar in order to make the right diagnosis, because this temporal fluctuation of symptoms, physical and psychological, they should be documented prospectively, and they should be present only during the luteal phase. This is very, very important, because otherwise we include women that maybe they have symptoms across the cycle and they have only an exacerbation during the premenstrual phase. As you can see, the disturbance, either you want to call it PMS or PMDD, is highly heterogeneous. We have plenty of symptoms, physical, psychological, behavioral, and we know from literature that more than 200 symptoms have been associated with the premenstrual phase. And you recognize in this list that sexual dysfunction has been included in behavioral symptoms, and the only symptom that has been clearly described in relation with the premenstrual phase is change of sexual desire. And we don't have so many signals that other dimensions of the sexual response are part of the syndrome. It's very interesting, however, that several authors in the literature, and one group in particular, the group of Jean Stade, that we was a very big friend and of the gynecological endocrinology world, and now we have Nick Panay and other people, even in other parts of the world, in North America and in Australia, have been described some symptoms, some sexual symptoms as part of a clinical entity that it's very much associated with premenstrual syndrome, but also with other reproductive disorder that has to do with mood disturbances, that is perimenopausal transition and postpartum depression. What is this condition? Is a condition that we name progesterone intolerance, or we name as well progesterone sensitivity, that can be either spontaneous, like it is occurring with the menstrual cycle, but is also maybe induced by the use of exogenous progesterone or progestogen. And you see that low libido and even vaginal dryness, that is another symptoms that can be related to sexual function and dysfunction, have been associated to this bunch of conditions and symptoms that can be exacerbated before the menstrual cycle. So maybe there is a comorbidity of sexual dysfunction and premenstrual syndrome and premenstrual dysphoric disorder. And we will try to understand if this is true. What we know since many, many years, and we have many studies, but it's important I underline to everybody that they are small population, followed only for few months, etc., in different areas of the world, that suggest that there is still a sexual cyclicity in women that is driven by hormones. We have in the literature signals that we may have an increase in periovulatory sexual activity. We may have an increase around the time of ovulation of mental awareness and motivation. We may have an increase of masturbative behavior, and we feel more genital receptivity, and also state of arousal and pain threshold, as everybody working in the field of PMS, migraine, etc., know very well. This threshold is very much affected by sex hormonal fluctuation. But what we know also is that individual disposition and many intrapersonal and interpersonal aspects play a crucial role. And therefore, since women, they are a little bit still animal, but they are not so much animal, we really mask our spontaneity in sexual function and behavior. And we have so many other factors. They are affecting the way we feel sexually across the menstrual cycle. And there are plenty of data suggesting that the weekend is much more important than the menstrual phase of the cycle to drive sexual behavior. So when we want to study this issue, we have to take into account so many factors. Anyway, this is a paper I published so many years ago that really, sometimes I don't feel at ease when I look at these results. But you see that we were investigating at that time what happened during the phase of the menstrual cycle. Keep in mind that at that time, we were not able to distinguish very well between desire, meaning fantasies and motivation, and arousal, that is comprising nowadays both a mental component and a physical component, but at that time we were not able to distinguish very much. But as you can see very clearly from these old graphs, we were able to see a significant decline during the luteal phase and during the pre-menstrual phase of both desire and arousal. And it was interesting at that time to see that when these women, they were on combined oral contraceptives, you lose the good and you lose the bad, and you stay in between. So in our hands at that time in an Italian population, desire and arousal were going down during especially the premenstrual phase. This is a study I like very much also because it's performed by a group that has studied very much both premenstrual syndrome and even a little bit of sexuality from Northern country, Professor Backstrom. And he was able to produce in a small sample of women this very interesting study that tried to link sexuality, mood and behavior with premenstrual syndrome and some signal in the androgenic milieu. You see that in this small sample of women, they distinguish between those patients that they had the real premenstrual syndrome against women they had only exacerbation of premenstrual symptoms. And they were measuring, for example, sexual feelings. And you see that they were able to demonstrate that the ovulatory phase, it's really a period in which you see an increase of sexual feelings, for example, and is the period in which you have the best mental score, meaning that you feel better. But this is true only for women with pure PMS. This is not true for the other patient that probably they have mood dysfunction during the entire menstrual cycle and they have only an exacerbation. And I'm showing you these results just to stress the idea that the diagnosis of PMS is very, very important if we want to collect data in research, and also if we want to propose treatment to our patient, taking also into account that the comorbidity between mood and sex is very, very strong. And even though we don't have a clear signal of a sexual dysfunction, when women are moody, probably they have some kind of problem in their sexual life. You see that when their group tried to link androgen to sexual behavior and to mood, the picture was not so clear at all. What they were able to demonstrate that sexual feeling, sexual thoughts, and even the contrary, unpleasant sexual thoughts were strongly related to the fluctuation of estradiol and progesterone, as you can see from the graph, because you had the best sexual feeling and the pleasant sexual thoughts around the time of ovulation in women, whereas the unpleasant at the very low level during the periovulatory. But dividing the population in two different groups, the one they had high androgen, the one they had low androgen, results, they were mixed. And this is not surprised because you have to think about that it's very difficult to correlate blood levels of androgen to mood and sexual behavior. But for sure, what they were able to demonstrate as well is that those women, they had the pure PMS, they had significantly lower level of testosterone and a significantly higher level of sex hormone binding globally in comparison to the one they had only premenstrual exacerbation. So this means that probably a signal with androgen is there, but it's really related to a subset of vulnerable women. And we should study more about this because I have to tell you that there are not so many studies in the literature investigating this topic. But to go back to the definition of PMS and PMDD, you see that in spite of this signal we have in the literature, but probably because they are only signal and they are not a matter of fact, there are no symptoms related to sexuality in the diagnostic criteria we have for PMS and PMDD according to the ACOG, so the American College of OBGYN, that look more at affective and somatic symptoms together in comparison to the American Psychiatric Association that look only to the cluster of mental symptoms. So sexuality is not included in this diagnostic criteria, and we should not consider sexual dysfunction as part of the syndrome. However, it's very important that I remind also to give you some tricks and tips in practice that when we do a sexual history in women, we should always consider the use of the most common drug they are considered for the treatment of PMS and PMDD, because you know very well that we don't have so many drugs in the gynecological endocrinology world. We don't have the time to go throughout all the treatment that have been proposed. You know that we have some kind of supplements, magnesium, we have the use of hormonal contraception, but it's not for everybody. It's important I remember to everybody that the most common treatment they are proposed to women with PMS and PMDD as really SSRI, SNRI, tricyclic antidepressant, benzodiazepine, antipsychotic, and mood stabilizer. And keep in mind that many of the side effects of this drug are really on the side of sexuality. So we may encounter many women, they improve their mood with this drug and they improve PMS, but unfortunately they develop sexual side effects. Another very important aspect that have been investigated in the PMS-PMDD world, but the literature is not concordant, remember, is also an history of abuse and intimate violence that is very common in women. They have chronic painful condition, including PMS. And we have to keep in mind that this is another very important point also for female sexual dysfunction. So in essence, if we want to study the correlation of these two conditions, we really need to learn more about taking a very good sexual history and not only using some kind of question. But another very important point I want to make with you today that probably we don't have to look after the circulating level of hormones, because we know that PMS and PMDD and even female sexual dysfunction, we may say, has been investigated from different angles of reproductive endocrinology. And the only signal that it's very crucial for mood, and you will see even for sex, is the conversion of progesterone in neurosteroids. We have here Professor Genazzani, I think he is one of the best person to comment on this topic among not so many others, because we know that neurosteroids, they play a crucial role in the neurochemistry of the brain, modulating different aspects of the androgenic production within the central nervous system. We know the HEA, but we know as well allopregnanolone. And why I'm telling you this? Because internal forces, they are hormones, they influence the chemistry of the brain, not only for mood, but you see here from this cartoon, also for sex. And so when we modulate the neurochemistry of the brain, in particular, the balance between dopamine and serotonin, we may affect sexual desire. Whereas we know that when we modulate serotonin and even GABA, I go back, we may modulate the mood and behavior, and we know that GABA and serotonin are so important for PMS and PMDD. In the brain, progesterone metabolites, especially the HEA, but also allopregnanolone, are very crucial, because we know that sexual behavior is modulated not only by estradiol, not only by testosterone, but also from progesterone metabolites. They affect essentially the receptivity. And we have many signals in the literature indicating this. But, you know, we cannot translate the data we have in animals, in rodents, to human sexuality. There are not so many studies out there. But you see that have been strongly investigated these aspects of the role of allopregnanolone in modulating sexual receptivity, facilitating lordosis in some models, inhibiting lordosis in other, and in essence, influencing the reward system, especially the dopaminergic system. So we need more study to investigate this topic. In the past, together with Professor Genazzani, we tried to investigate this issue. Then, unfortunately, we didn't go on with this research because, as you know, it's not so easy to measure allopregnanolone in the blood. And but you see that we published more or less 20 years ago that there is a positive correlation between sexual desire and allopregnanolone. And this is true in both phases of the menstrual cycle. There is also a correlation with scores of female sexual dysfunction. The only parameter of the domain of the sexual response that does not correlate with allopregnanolone is pain. And this is something to do probably with what Peter will explain to us, that women, they have pain also for other reasons. They are related to the genital and they are not related to the brain. So keeping in mind all this, I want to share with you my last 5 minutes, some research we are doing, trying to understand better this link between PMS and FSD. You see that in the literature, there are not so many studies and they are culturally driven. I select some. You see one in Polish, one in Turkey, and one from a very good friend of ours in Brazil. And you see that according to the culture, according to the instruments you use to measure PMS and sex, you do survey, you do validated instruments only for one condition, validated instruments only for another, you may find different results. For example, the presence of PMS is considered a risk factor for sexual dissatisfaction in Polish women of reproductive age. It's very important in Turkey because women in Turkey, they report a lot of sexual difficulties and even higher level of sexual distress associated with PMS. And this is a study, one of the few, emphasizing the importance of sexual aspects in PMS. Whereas, for example, in Brazil, by using a validated instrument, PMS does not affect at all female sexual function. So we have to use the right instruments. I want to show you the one we are using now at my university, and they are validated across the world. And of course, it's very important you validate also in your reality. We did this validation of this instrument that is very famous, the calendar of premenstrual experience. We validated in Italy with Professor Facchinetti, a good friend of gynecological endocrinology, more than 20 years ago. And you see that in our country, the factor 1 and the factor 4 are the one more relevant to drive the score that help you to make the diagnosis. And maybe this is not the same in other countries. For example, in North America, where they produced the tool at the very beginning, all the factors that were important. And we produce a score in order to diagnose the real one. So the women, they really have a pure premenstrual syndrome in order to select the good population. Then, of course, you have to use the right instruments to measure female sexual function. And I think it's important I remind to everybody that this is the validated instruments across the world and in many, many languages. That is the Female Sexual Function Index, a 9-item self-administered questionnaire designed to assess overall sexual functioning with a cutoff score of 26.5 that, however, measure all the different domains desire, arousal, lubrication, orgasm, satisfaction, and pain. And my suggestion is always to consider the scoring of the questionnaire, but also to consider your own population, because sometimes in different settings, according to the culture, the score may be quite different depending on the age, depending on being in a stable partnership or not. So it's always important to pay attention and to take into account all the other interpersonal variables that in some way they may affect the performance of this question. And another tool I want to propose to your attention that is very much used in the gynecological world because it's simple. And there is also a short version, a 6-item short form that you can easily use in your practice. It's validated in Italy. It's validated in Northern country and in North America, is the Psychological General Well-Being Index that can be used to assess the discomfort during a menstrual cycle. So this has more to do with general PMS, mood, and behavior symptoms associated with the cycle. But also these women may be relevant in our practice. So maybe they don't have the pure PMS, they have just a discomfort with the cycle. And I believe that when we want to work well in our office in reproductive endocrinology, we have to consider also women with mild symptoms. And in here, I want to just share with you an example of our practice and how this can help us to perform better with our patient. First of all, look, it's interesting to observe that in a population of more than 200 young women coming to our office just because they request hormonal contraception, so we are supposed they are quite healthy, you see that PMS is extremely highly represented. Keep in mind, I work in a university hospital, high level of education, and we have 39% of women they can score for PMS according to the calendar of premenstrual experience. And also, we have 33% of women they score under the cutoff for female sexual dysfunction. So these disturbances are highly relevant in the clinical setting. But when we consider women with PMS, so a COPE score that is pathological, and we go and measure the total sexual function, you see that we see only few differences. So our data are more in accordance with the Brazilian very recent paper that was published by Dr. Osorio. You have a little bit, some women, they go down. And look the different dimension. There is a tendency that is not significant. The group is quite big. So maybe if you increase the sample, but the power analysis say that it was enough to detect this difference, in which you have, so probably there is a subset of women, according to Professor Backstrom data, that they have low desire associated with PMS, but in our hands is not significant. No different on arousal, so at variance to what we published 20 years ago, because now we have a better methodology to assess this. No, but also little bit difference, but not significant in hypoactive sexual desire disorder, so meaning low desire associated with distress, but not clear signal at all. No signal in terms of lubrication and pain, so confirming data from the past. But look what we found in accordance with the data from Poland. Low level of satisfaction, sexual satisfaction in women with PMS. So there are some signals in our hands confirming different data from the literature. What is more important, and I finish with this, is that women not having any kind of female sexual dysfunction, they have a better well-being associated with the menstrual cycle in every different domain. not only the mood, but also vitality, also fatigue. The questionnaire I showed you before. So I really believe that as a first step to try to figure out if menstrual symptomatology may be related to FSD, we should use simple tool in order to assess well-being in women. Whereas probably when we assess PMS and PMDD, we have to consider this condition more related to depression, more related to anxiety. So something that has to do more with the psychiatric world and with the psychiatric attachment of the sexual dysfunction. I hope with my talk, I gave you some suggestion for practice and also some suggestion for research. And I wait you all at our next call. Thank you for your time and attention.
Thank you. Thank you. Thank you, Rossella. Thank you so much. And it's now my pleasure. We have a lot of questions already coming, and we have Rick Van Lunsen. He was putting an interesting one. We will be back to him later. And I am now inviting Peter Chedraui to speak about another point of very big interest, is the evaluation of sexuality of mid-aged women. Please, Peter, you can go on. Peter, can you open your audio? Yes.
Can you see? Is it okay?
Yes, perfect.
Okay. Thank you. I would like to thank Andrea and the board of ISG for the invitation to this nice webinar. And it's a very, very nice pleasure to be co-acting with Rossella Nappi, a very good dear friend from Italy. Thank you very much for the invitation. Now we're going to speak about the evaluation of sexuality in women who are mid-aged. Right? As an introduction, we can say that sexuality and sexual health are very important aspects of human health and well-being. And this is in sexuality, it per se is a very complex and can be influenced by biopsychosocial aspects, not only endocrine, as Rossella said, there are many factors that are interacting in the sexuality. Age, as women age, females' reproductive capacity it decreases and sexuality activity satisfaction decreases. Approximately 25 to 43% of the general population suffer from female sexual dysfunction. The climacteric or the menopausal transition increases the risk of sexual dysfunction threefold, more evident between 52 and 65 years, basically due to the decrease of ovarian estrogen secretion. As we can see in this classical slide, sexual dysfunction interacts with menopausal transition. More in the late menopausal transition, when 8 years have passed during the menopausal transition, as comparison to 1 year, when we compare 42% with 88% when in the late menopausal transition. Sexual reported distress associated with low sexual desire in menopause. We can see that women who are naturally menopause have a lower percent of self-reported distress as compared to surgically menopausal women and surgical menopausal women also. There's a correlation with low estrogens in association with increased prevalence of sexual problems. As we can see in the slide, women who have estradiol levels less than 50 picograms milliliters have a higher prevalence of vaginal dryness, bothered by problems, dyspareunia, pain, and burning sensation. There's also a role now, a preponderant role of androgens over sexual function, and this has been described, and there's more and more data relating or correlating the levels of androgens, or at least the correlation between testosterone and sexual function in the influence of libido, fatigue, motivation, mood changes. And this has been a situation or an issue of a lot of debate, the use of combination of androgen, estrogen, or androgen alone in comparison to placebo to improve mood states and general well-being and sexual function per se in women who are mid-aged. Sexual dysfunction during the perimenopause is very evident because there's a decrease or loss of lubrication, a very important component of sexuality of women who are during or passing or transiting the menopausal transition, less participation and response to stimulus. The frequency, duration, and intensity of orgasm decreases also. And this is always like a cycle, a vicious cycle. Lubrication decreases the coital frequency and increases pain, and there's a circle, a very vicious circle. And there's also an absence, and this has been correlated to androgen levels of sexual fantasies and less gratification, and decrease of sexual interest and decline of sexual activity increases with the perimenopause. With this slide, we can see that female sexual dysfunction or female sexual functioning is correlated with physiological, psychological, social, cultural influence and interrelationships, not only during the mid-age, directly correlated to estrogen levels, ovarian steroids, but also with all these factors that correlate between each other, which we will analyze some of these and some of our data that we have performed a lot of research in Latin America. Quality of life impact over low sexual desire is also an important correlation. There is a correlation between the lower quality of life with lower physical satisfaction, low emotional satisfaction, low general happiness as the women transit the menopausal transition. The prevalence of female sexual dysfunction is not very easy to calculate because many of the samples have been drawn from the general population are scarce, and there's no complete data or scenario to know all research that we have performed, at least us, we have performed with convenient samples, random samples of women who are mid-age, but it's difficult to calculate the general. But in general, there is a correlation between the decrease of estrogen levels, aging, and female sexual dysfunction in the context of the clinical context, and the variation of sample sizes have been observed in the majority of papers. This is a very interesting paper we published in many years ago with the Red Link, who was directed by Juan Blumel, and where we measured sexual dysfunction in mid-aged women using the female sexual function index, the complete tool, which Rossella described very well, which has 19 items and has a cutoff value of 26.55. In this sample of 7,243 mid-aged women, we determined that sexual activity, inactivity was higher among as age increased, lower education, postmenopausal women, and the use of HT was lower in women who were sexually inactive. We determined that in correlation with those who were sexually active, 5,391, the prevalence of the percentage of sexual dysfunction of the partner was high in several countries. For example, in Bolivia, 45.8% in comparison to Colombia and Cartagena, 10.9%. But as women age and their partner age, the percentage of sexual dysfunction in the partner becomes a very important component of sexual dysfunction in women who are mid-aged. And the percentage of sexual dysfunction, according to the cutoff value among the sexually active women, we can see there's a wide variety, also a 21% seen in Chile in comparison to a 98.5%, very high in Quito, Ecuador. Okay, with a general prevalence of sexual dysfunction according to the cutoff value of the complete 19-item FCSFI tool is 56.8% in these women who are mid-aged. We found that the main factors associated with sexual dysfunction, or at least impaired sexual function, according to the FSFI, in these 5,391 women, were the basic, or the most important one was bad lubrication. And as we see, other related ones are age, and the partner failure. Sexual function is a very important aspect also in this regression model that we analyze in these high or increased sample of women. Other studies have also correlated in cross-sectional studies of 800 women or so, 40 to 60 years. They have related low desire for their partner related to age, education, alcohol consumption, vaginal dryness, and with lower sexual satisfaction, age, and vaginal dryness. Professor Blumen in 2002 also determined with a tool, a very important tool, the percentage of problems related to desire, arousal, or orgasm and dyspareunia increase as women age from 40 to 65 years. In this multivariate analysis of their study in 534 Chilean women, they found that this was correlated to hysterectomy. There are studies, very controversial studies regarding sexuality and hysterectomy, age, menopause, and as you can see, decreasing this risk of sexual dysfunction is the perception of women having normal health and the use of HT. We also performed a similar study using the Lawman criteria, which was the one that Professor Blumen used, and we can observe that the sexual dysfunction presence increases as women age from 71.6% to 92% in women aged 60 to 65, with a mean average of 78.4% in women aged 40 to 65. In our regression model, we found that the most important factors were a sexual dysfunction of their partner, and the use of female antidepressants was also important. And decreasing this risk were having more education, being professional, and coital frequency is very important, and as well as other aspects, psychosocial aspects. We also performed the same using the same sexual functioning index tool in women from Ecuador, and we determined also that the male component is very important, as well as the age of the partner and the schooling of the partner, as well as personal data, age, the menopausal status, and as you can see here, other aspects like the use of HT are very important components of decreasing this sexual dysfunction. With using the total tool, well, with the cutoff value of 26.55. There are also tools that are not so specific for sexuality. They are general menopausal tools, but they have some domains of sexuality. For example, in this Toronto, the University of Toronto has this MenQual, the menopause specific quality of life questionnaire, which has 29 items, but it has 4 domains: vasomotor, psychosocial, physical, and sexual, with 2 items. Higher scores indicate a decreased quality of life. More than 50% of women from Ecuador, in a sample of 325, had scores of the sexual domain above the calculated median of 4.9. Diabetic women were 2 times at the higher risk of having sexual domain scores above the median. Then we moved to another study that we performed with the Society of Climacteria from Ecuador. When I was president of the society, we did a national sampling using the 6-item female sexual function, which is a short version of the 19-item. It includes the 6 domains of the complete item, of the complete tool, but only using the specific questions of each domain, which gives us a shorter tool, which is more practical for a clinical routine. Like Rossella said, if sometimes we don't have time to make a complete assessment, and which takes time in the general practice, especially when we are in a general hospital or a university hospital, we have to be very quick. But we need tools that can validate or screen certain signals and items that are important to assess, which is the real problem. This is the short version of the FSFI, which was validated by a group of Italian group of research, and they determined the 6 important questions that comprises the desire domain, arousal domain, lubrication, orgasm, satisfaction, and pain domain. Using this short version of the FSFI in 904 women from Ecuador, we determined that there was a Higher scores in the FSFI indicate better sexuality. Lower scores indicate lower sexual function. So there was an inverse correlation with living at altitude. As you can remember, one slide we saw, there was a high prevalence of sexual dysfunction according to the complete tool in women living from Quito. A history of sexual abuse, another important aspect, is sedentarism. We have not found, we have performed, and as we were speaking earlier with Rossella, before we started the webinar, the aspect of obesity in correlation with different aspects of sexuality, of metabolism, and in women who are in mid-age is very important. This is not directly correlated to obesity, but we found that sedentarism, which may be correlated to obesity, is in inverse correlation with sexuality. Also, an important aspect is the correlation between the sexual function and menopausal symptoms, which seem to correlate in between, not only with menopausal symptoms like hot flushes, also with depressive symptoms. And again, we have inverse correlation with all the aspects, as you can see, of the partner, and coital frequency is directly proportional. Higher coital frequency with better sexual function in this group of female mid-aged women. And we also performed a sampling in Paraguayan mid-aged women, and we found a similar model, a higher coital frequency, better sexual function in mid-aged women. In these 223 urban living women, and postmenopausal status and age were inversely correlated. In one sampling that we did with the MENCOL, as I mentioned already, women who had hyperglycemia had higher scores and more decreased libido in comparison to the women who had normal glycemic levels, and the total scores were higher in women who had higher glucose levels. We also compared women in our cohort of women from Paraguay, the women who had there was a correlation between depressed mood, independent, using different models of analysis of regression, with sexual function. In this slide, we can see that women with depressed mood presented higher rates of sexual function index, less than 19, which indicates that there's sexual dysfunction. In other words, women who have depressed mood, there's a higher prevalence of sexual dysfunction. This is a very controversial issue, the correlation between hysterectomy and sexual function, but we performed many years ago, 10 years ago with Professor Hidalgo. We recalled women who had hysterectomy to see how their sexual function was, and we found that there was a correlation between in the different aspects of the, but this is the complete item tool, between age, the use of contraceptives with lower functioning, sexual functioning, age, partner alcohol abuse, which is another important factor in certain countries of Latin America, the correlation between alcohol abuse of the partner and intimate violence with sexuality. Ethnics and sexuality function has also been studied. We studied with Professor Blumel and Alvaro Monterrosa in women, comparison from women who are mestizian or Hispanic and with Afro-Colombian women, and found that scores for desire were lower in women who are Afro descendant, but we found higher scores of lubrication and orgasm satisfaction and pain, with a total score of dysfunction lower in women who were Afro descendant. Just some tips, as Rossella said, the clinical history for the assessment of female sexual dysfunction should include a specific description of sexual dysfunction and the current analysis of sexual functioning, the moment of initiation and progression of the problem, patient's theory of the cause of sexual dysfunction is very important. Some women can clearly identify their problems with that they have intimate partner violence or alcohol abuse, precipitating factors, the effects that sexual dysfunction had over personal relationships, prior treatments and outcomes, understanding physiology and sexual behavior, and also trying to understand misleading myths and concepts regarding sexuality, especially during this menopausal transition. The obstacles to routine sexual history are physician time constraints. As I said already, when you're working in a general hospital, a university hospital, you have 15 minutes. You have to be very quick. So sometimes there's no time to make a complete assessment of sexuality. The discomfort of the topic, speaking about this problem, women, is sometimes disturbing, and sometimes these problems have to be assessed with the partner present. It sometimes does not go to the consultation. Limited training in female sexual functioning. As general OBG, we're not specifically trained in some of these aspects of sexuality, and the lack of treatment options, because some of these treatments are not, in the case of women who are transiting the menopausal transition, it may be very useful, the use of estrogens or estrogen androgens, menopausal therapy, hormone therapy. But sometimes if the problem is not related specifically to the lack of steroids, the treatment may need the assessment of a very trained person in these aspects of sexuality. So in conclusion and recommendations, women who are transiting who are mid-age, sexual dysfunction is multifactorial and definitely impairs quality of life. In Latin America, the prevalence of sexual dysfunction is very high, in which the male component plays a very important role. More epidemiological data should be carried out to confirm this and explore more social aspects of sexuality related to the menopausal transition. The management should be preferably preventive and directed towards biopsychosocial aspects, and which is now very researched, evidence research of androgens and the combination of androgen estrogen to have an positive impact on female sexual health. I thank you very much, and as Professor Genazzani will say, we invite you to our ISGE Congress in May, and that I think it will be a very, very good success. And I believe it will be totally presential, caro Andrea. Thank you very much. Grazie. Molte grazie.
Thank you, Peter. Thank you all. Okay, I think that we are just receiving already a series of questions. And Rossella, you are here with us. Please open your...
Professor Nappi had a problem. She is reconnecting.
Okay, then I think we will start with some questions with Peter. You know, the topic is very, very important and attractive. And we have, I will start with a question from Rick Van Lunsen directly to dear Professor Chedraui. How do you explain that many perimenopausal women experience sexual pain and dryness, while it has been shown over and over again that irrespective of the degree of atrophy, there is absolutely no difference between pre and postmenopausal in levels of arousal and lubrication when sufficiently stimulated? Please, well, Peter, do you have any comment?
According to the data that we have just seen, that maybe not only the decrease of estrogen levels brings a component of lack of lubrication, which also is combined with pain, right? There is also a decrease in the sexuality of men, and this does not help or aid to increase the stimulation. This is a very difficult aspect to assess, but what it is true that at more coital frequency, there is less lubrication and there's more stimulation, but this has to be combined and aided with some topic or use of estrogen directly and use of certain lubricants, and the age of the age of the partner is also important. You know very well that the component of women that age with the decrease of estrogen is also in correlation with the age of the partner. In some countries, I must say, in Latin America, older women like younger men because they can be more stimulated. So I think this is a very simple question to assess. I think Rossella can complement with this very importantly. Yes.
Yes.
Yeah, if I may add, sorry, I missed the signal for 2 minutes.
Yes, you can.
I don't know if you discuss the issue of use it or lose it, because You know, to have more sexual intercourse may mean that you have more desire for your partner, and this will be positive and can be related to androgen and not with estrogen.
Right.
And so you have more sexual intercourse. There was a very famous study by Sandra Leiblum back in the 80s, suggesting that these women with more sexual intercourse throughout menopause, they were the one with the higher level of androgen in spite of the same dyspareunia and low estrogen. This is interesting, in my opinion.
Yes.
Thank you, Rossella. And it's also a question for you on the role of treatment of PMS on sexual function.
Yeah, which question? I saw one by Rick, and he was.
No, I will go. You have not to go on the list. I will make the question, please.
Okay.
You ask,
okay.
I will make directly the question. Then this is another one on the role of treatments of premenstrual syndrome on sexual function, because as you know, we have in one side the antidepressive negative impact and so on. Please, if you can go a little bit on that point.
Yeah, sure. Rick was suggesting that there are some antidepressants, they can spare sexual function, or at least they have less side effects, such as, for example, bupropion. The problem is that we don't have so many data on PMS, PMDD, because the link was between these two conditions, and we have to consider that the majority of data we have with PMS are with SSRI, especially the old one, fluoxetine, sertraline, venlafaxine, etc. And so we see a lot of side effects in these women, unfortunately. And therefore, we can even propose this new treatment that has been marketed, at least in North America, US and Canada, to counteract low libido, for example, flibanserin, but we don't have in Europe. We were not able to demonstrate that they were effective across Europe, because the cultural issue is very important, as I told you. And I believe this is important both for PMS and FSD. I see a lot of similarities in the way we should assess these two disorders.
Thank you. And concerning Dr. Chedraui, Peter, comment about the utility or not of short tool to assess sexual function in clinical practice, because this is something that the gynecologists normally they forget about.
Yes, well, as I showed that my data, that it's much more difficult to run a questionnaire with 19 items, which will take you maybe 40 minutes or maybe an hour to complete. Sometimes in some countries, women don't even understand any of the questions. So I think that, you know, tools that are, as Rossella said, the shorter they are, the more effective they are, and you can have an overview of which aspect is the problem, so we can act directly over the domain which is affected or whatever, and correlate data much more easily with, much more easy tools to fill out. Right, Rossella?
I agree. On one hand, we should use a shorter tool, but in my opinion, we should use a tool that assess the biopsychosocial model, because unfortunately, the tool we have in our hands, they just measure the different dimensions, but they are not so good in picking up what is biologically driven and what is psychological, relational, and socioculturally driven. So we have some, for example, the screener of low sexual desire, in which you have only 5 questions and you try to understand what's going on. We have another that is the short experience in sex that Lorraine Dennerstein used in Australia. That is a tool that is able also to pick up the partner, the role of the partner, that, as Peter said, is extremely important. And, there are not so many data, for example, on the role of the partner in PMS. This is very important as well, if you think about. And if you have a supportive partner, maybe this will be positive for your sexual life. Whereas if you have an opposite, or You know, you just, as you know, women, they are very nervous in their family with their husband. And so this is inducing some kind of dysfunction. So it's very difficult in a short term to address all these issues. But our goal should be to produce multidimensional instrument. This is my feeling. Otherwise, we oversimplify the issue.
There is now several questions. I will make a resume for both of you. And that one, they originate from Bentina, from Siegfried, from Anna Paula Di Bello, from Fernando Avila. The question is, what is your, your form of application and dosage for replacing androgen? And then what about your opinion concerning the different androgen molecules, testosterone decanoate, or other androgen preparation, and also the HEA? I make a mixture. Then I would like to have one comment of the one and the other. Please, Peter.
Rossella, I think that you are very much more expert on this than I am, but I agree.
Okay, then Rossella, please go on.
Okay, you know, I believe that it's important to understand that we have different attitudes across the world. The first concept we have, you are probably aware that we had a consensus global position statement from many societies on the use of testosterone in women with female sexual dysfunction. And the suggestion from this meta-analysis is that we should use transdermal preparation, because this preparation, they have data, or at least more data on safety. I know that in Latin America, in Central America, in other areas of the world, and also in the UK, for example, there were in the past androgen, there were implants or injection. Or even in the past in North America, we used oral methyl testosterone. But unfortunately, this is not in the recommendation, at least to reverse female sexual dysfunction in postmenopausal women or perimenopausal women. Usually, we use products that are testosterone on one end, we use the gel, they are marketed for men, and we try to use to replace the physiological range of testosterone we see in premenopausal years, and we use the dose that was published with the patch, 300 microgram daily. So you can use 1/8, 1/10 of the dose that you have for male, the standard sachet that you have for male. I have to tell you that I am a pupil of Professor Genazzani, so I use a lot of the HEA. As you know, it's very difficult to find the right fix, because according to the preparation of the HEA, the way women metabolize the product, and probably also the way different organs are capable of metabolize the drug, makes the difference. And I'm sure Professor Genazzani can comment on this. But when I have women, for example, with mood disturbances in premenstrual phase, or in post-menopausal women, I use the HEA. I start with a low dose, usually 10 or 15 milligram. Then I go up, and in my hands, 25 milligram can be okay, meaning they can support women around perimenstrual phase, and together with estrogen replacement therapy in postmenopausal women, they can do some good. There is a lot of variability, however, and this is the reason why we have to understand more on the metabolization of the drug on one end, and probably on the comorbidity that give origin to low libido. And if I may say a last word, according to the guideline, we say, if following 6 months, give a try to androgen. If you see they are low, the HEAS is low, you have other symptoms of androgen insufficiency syndrome, give a try to androgen, either HEA or testosterone, and if following 6 months you do not obtain any significant result, you stop it because probably there is something missing. It's a pity that the HEA is not in the guideline and only testosterone has some data coming from meta-analysis. So we should study more the HEA. This is what I am suggesting to everybody.
I totally agree. I
I
totally
agree with
agree.
Rossella that the androgens should be used specifically when there is a cause that can be identified. But as we said already, there has to be a global evaluation of other aspects, which are also very important components, comorbidity, personal aspect, social, cultural aspect that also have to be very, very closely analyzed. And you know, testosterone might not be the greatest panacea. Okay, so this is my complementation to her comment.
But Peter, there is a specific question on comment about the interrelationship between symptoms, menopausal and depressive, with female mid-age sexuality.
Well, as we've seen in some of the regression models, there's always like an overlap. Could be, you know, the interlapping or the overlapping, but maybe the intensification of some of the sexuality symptoms with higher intensity of hot flashes or more depressed mood in correlation with sexuality. And this is very important to analyze not only sexuality from the sexuality point of view, but also with other global aspects of menopausal symptoms like depressive symptoms, the correlation or the co-participation with the partner, which can also cause depressive symptoms if they have a personal interrelationship problems, which could intensify depressive symptoms, hot flashes, and therefore sexual problems also. I think that these aspects are also interrelated, which would be the correct, they are closely related.
Thank you. And there is a question from Ashraf Irmani to, I think, to Rossella. What about the use of nutraceuticals, behavioral therapy, and other novel treatments for female sexual dysfunction?
This is a very interesting question because I decided to skip nutraceutical and to skip treatment in general because we didn't have so much time. But there are some natural compounds that can be used to improve mood and sexual behavior. We are now analyzing a population of women taking a mixture of substances. They work more mood, on energy, because I strongly believe the effect on sexuality is a combination of an effect on mood and an effect on fatigue. Because keep in mind that when you feel fatigue, you really don't have the energy to devote to sexual function. And this is very common in women, especially in the age range between 30 and 40, 45. We don't know if it's really androgen, if it's really because they are overloaded and very much stressed. But to support women with nutraceutical is important. Unfortunately, this study, they are on small cohort of patients, and this is the reason why it's so difficult to include a nutraceutical in guidelines. At the present moment, we have only magnesium, we have only vitamin B6 that are for PMS. For female sexual dysfunction, we don't have so much evidence, but we hope we will have in the future.
Thank you. Peter, there is a question. And can the progesterone used in menopause hormone therapy have distinct impact in women's sexuality? And the progesterone with sedative effect, as micronized progesterone, could have a negative impact. I would like to tell you that you haven't made a distinction between the oral administration of micronized progesterone, who can have sedative effect, while the vaginal administration is absolutely minimal effect in this context. Can you make a comment, Peter, about
what I would like to comment is specifically that I think that the MHT, the menopause hormone therapy, should be guided directly to the specific cause. If the evaluation of which is the aspect needed for to be treated. And in this case, for example, if you use a very important tool like the MRS, you can determine if women have more sexual, if the component is more hot flashes or it's more depressive, or it's more sexual, we would use the component which is best. For example, if the domain which is affected is more the vaginal part, I personally prefer to use local systemic estrogen, estriol, right, directly to the vagina, right? And if the symptoms are correlated with hot flashes, the use of transdermal, which is the best, and combined with a natural progesterone, micronized progesterone, which would give you less androgenic effect and less mood swings that would correlate with sexual dysfunction. So I think that this is the best. And definitely there's another important aspect that is now we recently published a paper in women who have had a bilateral oophorectomy. The use of estrogen is very important because women who have surgical menopause, as we saw, have more problems earlier than women who have natural menopause, and this has been correlated with the use of estrogen, which is very important. I think that this is what we can complement.
Thank you, Peter. And Rossella, there is a question from Batul Rashidi. What is your recommendation for sexual problems in young breast cancer patients taking letrozole?
Yeah, this is a very important question, my dear friend, and there is no one single answer. I usually propose to these women, first of all, education and counseling. Then we use lubricant and moisturizers. Now we are gaining experience with this thermal energy device. I have more experience with radio frequency, but we use as well laser with some friends in Milano. And we can achieve some benefits. As you know, unfortunately, there is still a contraindication in these women to the use of local estrogen. We have now the possibility to use local progesterone, but it's still a contraindication as well, even though with the HEA, we suppose that we have an intracranial effect within the cell, that this effect is mostly androgenic, and therefore not have any side effects. Indeed, there is one study by the group of Susan Davis using for 12 months in this, for 12 weeks in these women, local testosterone cream. And this is published data. So now, of course, with a stronger discussion with the oncologists that they are always against everything, even though they are evidence-based, I discuss the use of local androgen in these women, because we have data. Of course, we don't have safety data, but at least we have data of effectiveness. And I strongly believe that a low dose of testosterone local in the vagina, even if it will go into the circulation, will not do so much harm to breast cancer patients. They are on aromatase inhibitors, okay?
Yes,
so I believe that it's a biologically plausible that we can use this compound to help these women. And it's also important to complement sometime with psychosexual counseling, exercise, physical exercise. Remember, the biopsychosocial model is essential, in my opinion.
Yes, thank you. And also I have to make a comment that on that point, while FDA have also agreed that progesterone and local DHA 6.5 milligram capsule, vaginal capsule, can be given also to breast cancer patients, the Human Medicine Agency, they have not yet taken the decision, and they are asking more specific studies on that point. Then there is now an interesting question. If any of you have any experience of what's happening with sexuality in trans patients going on with the age. Peter?
I have no experience.
Rossella?
There are few studies, and actually they behave exactly like all the other human beings, because they are exactly like the other. And so they are facing the same problem, but unfortunately, they face the stigma. And therefore, there are only few experts because somebody that is able in expert in transsexual is not always expert in aging, you know. And therefore, when they live their life and they do consultation, they find only few experts. And so what I've seen is a lot of unanswered question, and we should do more for these people, for contraception, for menopause and andropause, because they really have a minority stress, because they cannot discuss with experts in their area about their feelings. And so we should work more for the aging person, even if transsexual, and the couple of a transsexual person. We don't have so many studies on that, only few experts.
Thank you. We have also now a comment from Paul Piet. Is to remember that oral micronized progesterone 300 milligram a day was shown to improve PMS symptoms in a double-blind crossover placebo-controlled study based on a publication by Lauren Dernerstein in British Medical Journal. This is true, but I would like to remind you that the administration of 300 milligram orally is strongly converted to allopregnanolone. Then allopregnanolone have a lot of improving effects on behavior and mood, and it was also mentioned by Rossella. This is dependent, I don't know so much on sexuality, certainly sexual response, but I certainly agree that the progesterone, you know, is something which is in your basic life and is an hormone full of effects for the brain, either directly as well by its conversion in the brain and in the liver to allopregnanolone.
I agree with you. It's a study that was published so many years ago. Unfortunately, it has been never replicated very much. Keep in mind that there is an evolution also of the definition. And in my hands, some women, they respond to progesterone and others not. And it depends really probably on the amount of progesterone that is metabolized to allopregnanolone, and it's really acting in the brain. So when you use high dose of progesterone, micronized progesterone, at least in my hands, I have a lot of side effects as well. So, you know, I'm a lover of Lauren Dernerstein pioneering study, but at the present moment, there was no replication in the literature of this, and it's not always working, I can tell you.
Thank you. And then it's now also a question from Luciana Bergamaschi. As you know, this happened in some countries, the HEA was not so easily available. Then they have suddenly started with pregnenolone administration. But I would like to remind you that we have no studies published on the use of pregnenolone, as pregnenolone is not going directly to the HEA. It's also converted to progesterone. And then, I don't know, I think that we are lacking of information about the safety and the efficacy of pregnenolone use for, I don't know yet on what kind of symptom. Do you have any comment, Rossella or Peter?
I don't use this bioequivalent molecule in my practice because they are not so well controlled. And I think we are a society that, you know, we always try to put together research and clinical practice. We should do research with these compounds. Unfortunately, it's not easy to do good research because they are not stable. We don't know the manufacturer, etc. So I believe that we should stick to scientific data for the safety of our patient, because otherwise, hormone, they will be considered killer women. They, you know, there are maybe other experts in other societies. They do natural medicine. They are better than us to do this. We can change ideas, but I don't have experience.
Thank you. And then a question to Peter. Comment regarding the importance of partner issue you were already mentioning and aspects and female mid-age sexuality.
We already commented on some of our slides that the partner issues, the male dysfunction, sexual dysfunction during who are partners of women who are transiting the menopausal, who are in the menopausal transition, correlates significantly with their sexual dysfunction. So it is very important to have a good relationship, like Rossella said, being supportive, even if maybe you might have your age, or if the support is very important to correlate with good sexual function in women, not only from the organic point of view, but also the psychological and social aspects are very important. And in Latin America, it seems that the partner is a very important aspect correlating with sexuality of mid-age women.
Absolutely, and also because male sexual fragility have also to be accepted from the men, and they have to go also to physician about that one. For that. And now, dear friends, we are at the end. I would like a final comment from the two speakers on the importance of to assess sexuality and to raise the proper sexual question in the good way to the patients, to try to maintain and improve their quality of life, and how gynecological endocrinology is important for that one. I would like to have a comment. First, Rossella, ladies first. Okay, please.
Thank you. I believe that in reproductive endocrinology, we have a unique opportunity to follow the woman from peripubertal years and adolescent throughout the entire lifespan. And therefore, we should start discussing sexual health since the early experience of our patient, just with a very simple question. Have you been satisfied with your sexual experience with your partner, maybe taking a pill or whatever we prescribe to our patient? In this way, we will help women to understand that we are the best friend ever for them to discuss sexual problem. Maybe we are not the best expert, but we can help them to raise the issue to discuss, because one of the most important aspects in sexual medicine, it's really the women, they wait long time to break the ice. They don't feel at ease in discussing this. And keep in mind that time you have a problem, the longer you have a problem, more difficult is to solve the issue. Logically driven. If you have your symptom for long, you will have also other interpersonal aspects that will give you a negative loop, and it will be much more difficult to be treated.
Peter, your comment?
I would like to close the webinar saying that as clinicians, we should support women who are transiting the menopause, support them completely, evaluate correctly, and try to, like Rossella says, break the ice to find out which is where's the origin of the problem. And in order finding the origin of the problem, we can help, therefore, and try to improve their quality of life. I think this is the very important aspect as clinicians.
And I would like, and I have to make a final comment. PMS and sexuality, middle age and sexuality, but elderly and sexuality is fantastic. You have to take care of your women. They can take of their men to maintain sexuality until the last day of their life. It's something who make the life smiling, who make the life wonderful, and who give you a sense of self-esteem that you cannot imagine.